This is the plan. So today you're getting 2 hours, about an hour from Shawna Pandya, another hour from me. And the basic structure of these 4 hours was suggested by input from the last year's first-year medical class. Now, this slide contains 74 words. Can you imagine that? And we have a feeling that because of such an extraordinarily large number of words that you may not have actually looked at what was here. So it says that we're giving you a sort of high-level overview of the next 100 years. This was never intended to be a short-term thing. However, the feedback from you is you wanted something short-term. So what Shawna is going to do is, rather than the next 100 years, she's doing the next 8 years to 2024, and with more comments about entrepreneurship than we had planned originally. However, those of you that were really looking forward to the next 100 years from Shawna, that already exists in the winter 2015 issue of New Trail on page 17, 18, and 19. So you can find it there. And I have a feeling that next year when we do this, we'll probably do the next 100 years, right? Because that seems to me intrinsically more exciting than the next 8. So there was another point that a number of you did not like last time, and that was Dr. White suggesting that you'd be out of a job at some point. And I just want you to know that I don't think that, but maybe what I think is even more dysphoric for you. I think a point may be reached when machines are smarter than we are, where we basically eliminate all current diseases. Every single one of them that you know about either becomes preventable or readily treatable. So there is no chronic disease whatsoever. And what will physicians do then? They won't be unemployed because of the human need or wish to be enhanced, the wish for enhancement. And we're not just talking about physical enhancement, talking moral, spiritual, and if you begin to think about that, you realize there's no end to the wish for that. And physicians are probably a better category to deal with human enhancement than any other, so we'll be employed for a long time, even when all other normal mortals are no longer on permanent vacation their whole lives because robots can do what they do better. So that's what I believe. I don't believe you're headed for unemployment at some point. So these were the qualitative learning outcomes. This slide has 61 words. Once again, it may have been way more than what you could possibly take in. I apologize for that, but it's a good excuse for you if you felt last time that what we were doing was entirely different from what we were intended to do, whereas what we thought is what we were doing last time was exactly what we intended to do. So, how do you feel about getting this kind of futuristic, speculative teaching? If it seems to you inappropriate, what I can tell you is government leaders, Clinton, Obama, the heads of the UK, Japan, Russia, China, so on, have gotten a briefing very similar to what you got last time. And this seems to be a permanent feature. And the original lecture that I gave that sort of gave the basic idea for the Technology and Future Medicine course was at the Singularity University reunion in August 2011. And the guy who spoke right after me is worthy of some respect. His name is Stephen Long, and he is the main technology advisor to the Joint Chiefs of Staff of the US military. And so you can listen to what he said, and you can also listen to what I said. But one of the things he said which you may have wondered about last time, is this singularity business. He said it's not a question of if, it's only a question of when. So this is what he's advising to the US military. Now you may wonder why his posted video says 4 years ago and mine says 5 years ago if we spoke in the same session. That's quite interesting. A year later he contacted me, told me that for national security reasons we had to edit his video. So we did, and that's the reason his video is from four years ago. Now, beyond this, government leaders themselves have been putting on sessions very similar to what you experienced last time. Obama did a series of public workshops at the White House, or sponsored by the White House, between May and July of this present year, 2016. They were all live streamed. They were very interesting, and I've put a link there if you want to listen to him talking about machine replacement of human labor. So that's external. What about the university? The university, the Central University has bought into this quite heavily, and I was kind of amazed at what happened with this issue. You know that there's a journalistic rule that ordinarily, with an ordinary person, you would only, for a given issue of the magazine, you would only interview them once, and there would be quotes from them only one place, whereas you will find in here there are quotes from me multiple places. I was interviewed many times. So, was that a serious mistake that the Central University made? Apparently not. Because for the first time ever, this magazine, New Trail, the alumni magazine of the university, won the award for Magazine of the Year in the province on the basis of this issue. So I'm not saying that those of you who objected to looking long-term are entirely wrong. I'm just saying that other people, like governments and the Central University, do think that it's valuable to take this long-term look. Now, this is a self-referential lecture. I'm kind of proud of that. I think a lot of other things have that characteristic when you get into the highest quality level, in that they are, right as they're progressing along, reflecting on what they're doing right then. Like Leonard Cohen's song, Hallelujah. Even if you don't know who he is, you know Shrek and so on. This is a very well-known song. Has the lyrics, well, it goes like this: the fourth, the fifth, the minor fall, the major lift. There he's talking about exactly the notes that are being sung. And what I'm about to do with you now is talking with you exactly about what we're teaching you this year. And those of you who said to me, looked me in the eye and told me last time that you'd like more of this, I want to give you some ideas of what more of this is possible and what's not possible. So you might think that it would be simple. You could go into the YouTube channel for our course, Lab MP 590, Technology in the Future of Medicine. Simply look at the most popular lectures there and say, well, we should be teaching you that stuff. But that would actually not work. The most popular lectures there are on quantum biology and nanotech. And we spend much of the time sort of preparing the students for the punchline, which comes quite late, like 5 hours into the teaching. So, giving you a lot of background. And the problem with that for medical student class, some of you already know this stuff and some of you don't. So it would be very unsatisfying to spend that much teaching time teaching some of you stuff that you already know, and others of you things that just don't seem relevant. I can relax now. I'm often in this situation, but when the main lecturer shows up, I suddenly am loose and relaxed, and I know everything is going to be good. Anyway, for that reason, the most popular lectures from the Technology and Future Medicine course are not really appropriate for you guys. Okay, so what about regenerative medicine, bioartificial organs? We could teach that. It's an appropriate thing for you to learn, but some of the best teachers in the entire university are in that field. So Timothy Caulfield, who's sort of a celebrity in his own right and writes books about, celebrity, he's one of the most engaging speakers you'll ever meet. And similarly, James Shapiro. So we're fortunate to have people like that here. You will be exposed to them for sure. So you don't really need that content from us, even though it's a popular part of the course that we teach. So what then remains? And one thing that had been suggested to me by a number of you, the students, and also seems rational to me, is if we're going to do more like this, it would be the ethics side. And we've quite a few excellent people who could teach that. And it's a very interesting question. As Osmer Zayan says here, if we teach these machines ethics, they will be more ethical than we are. So is that what we want, or is that not what we want? Then there are also questions about determinism, free will. These things really affect everything you might plan, right? Because they suggest that you only think you're planning, but actually you're not planning anything. It's already determined what you do, or you have limited free will, so on. That could also be an interesting area. And there's one other that I think one could consider for the future if we do more of this. Leslie Cormack, the Dean of Arts, gives a very interesting talk entitled The Elixir of Life, Magic, Technology, and Medicine of the Middle Ages, where she points out that in the Middle Ages, the situation was identical to what you currently have. For every malady, for every disease, there was a way to diagnose things, there was a way to treat things. We might think it was entirely wrong. Everything was sort of all wrong, but there weren't any questions that people didn't have answers for. And there were a lot of therapies and different ways of treating things. And basically, the medicine of the Middle Ages was as complete as the medicine of today. We now regard most of it as being entirely wrong, but it's quite interesting to think some of the medicine of today might also be wrong. And so maybe things are not quite that different from the Middle Ages. Okay, so Shawna Pandya, she and I have known each other since 2010. Although we're both from here, as often happens with people who travel quite a lot, we actually met quite far from here in Silicon Valley at Singularity University. And you may wonder about the dynamic between us. I'm about 40 years older than she is. So which way is the wisdom flowing? Is it flowing from me to her or from her to me? I guarantee you it's flowing from her to me, because I've learned a tremendous amount from her, and this is one of the first things I learned about wildcards. And some of you will be upset that we're talking about wildcards, and others very excited. But wildcards are those not very likely events that if they do occur will just change everything about the future. And so that one of the first times I heard about that was from Shawna. She has accomplished a very large number of things in her life. She's good at multitasking. Here you see her multitasking. She's both eating and dancing with me at the same time. And she looks much more fluid than me. You see, I look a bit stiff, and yeah, so anyway. But There is a single page you can go to learn everything about her, and has a very difficult to remember URL. It's called About Me / Shawna Pandya, and it will tell you all sorts of fascinating things about her. I will. So I would just love to read every word, but maybe I don't have to. But some of the high points, I mean, the things that might impress you about somebody, first of all, is she nearly your own age? Yes, she is. She's younger than some of you, older than some of you, but she's about your age. She's packed a tremendous amount of life experience. Into that short period of time, she's been to space. She's started an award-winning company. She has been to Singularity University, International Space University. She's completed scientist astronaut training, piloted a plane, flown in zero-G, co-founded a company based on a challenge to positively impact 1 billion people, perform brain surgery, work on a robot that performs brain surgery, assist in pediatric cardiac surgery, and hold a beating human heart in her hand, author a book chapter on space technologies used in everyday medicine, interview medical experts, brainstorm with Nobel laureates and astronauts, go to medical school, go to space school, walk the runway, sang opera, sing the national anthem in front of 10,000 plus people, compose music, scuba dive, parachute, spar and win, as a black belt in international taekwondo competition, mediate the silence for 10 days in the forests of Quebec, train Muay Thai alongside a Navy SEAL, complete 21,000 sit-ups in 30 days. You have to be impressed by some of these things. I mean, some of them may not interest you very much, but some of them every day keeps getting better and better.
So thank you guys for having me. I know this is the coveted last spot of the day before a long weekend, so I've made this as long and boring as possible. No, this is totally your lecture, so if you guys get really bored, you can signal that by putting your head down on your desk and falling asleep, and I'll try to change things up. If you have questions, make it interactive. That's how you're going to stay asleep. That's how I'm going to, or stay awake. That's how I'm going to stay awake. If you want to take this lecture in a different direction, that's totally fine. I have a few objectives I want to get through. If you've heard it before or it totally doesn't interest you, or you want to dive deeper, please let me know. So as you've heard, I'm Shawna. I'm a resident here, finishing up in general practice in 6 weeks, not that I'm counting. And today I want to talk to you about engineering tomorrow, the future of medicine. I know that you've had up to 3 hours of this previously. So what am I going to talk to you about specifically? I want to talk to you about concepts that I think will be relevant to you as you go through your careers as future physicians, as you go through your preclinical years, your clerkship years, residency, and eventually practice, things that are on the horizon but are starting to come into practice today, specifically technologies and concepts. And then for those of you who might be a little bit more entrepreneurial or hands-on or doers, we're going to talk a little bit about the mindsets and the psychologies that go with that. And then because we're talking about fringe medicine, things that we don't typically talk about in your curriculum, we're also going to spend a little bit of time on extreme environment medicine, because that's one of my personal favorites and where I spent some of my time. So if you have any questions at any time, just let me know, because I have questions for you. So first question, what are some of the greatest challenges in medicine today based on what you've learned so far? Are you stretching or raising your hand in the back? She was stretching. Yeah.
Integrating all different data. We have so much data, patient records.
Data, yes, we have so much data and it's only increasing. And the amount of data we're generating on a daily basis is now, orders of magnitude above what we used to in decades. So that's kind of impressive, but also a hindrance. Anything else? Yeah. Yes, it's like you guys have seen my slides before. That's awesome. Anyone else? Okay, so my next question is, what are some of the greatest opportunities in medicine today? Anyone? Even if you look like you're stretching, I'm going to call on you. So you should just stick up your hand. Yeah. Robotics, awesome. Yeah, robotics in surgery, robotics for the paraplegic and quadriplegic, and we're going to talk about that. Anyone else?
More targeted and personalized therapies.
Yes, perfect. So my last question for you is, what are emerging trends and technologies that can help us with each? Okay, so here's a little bit of a list that I made about challenges in medicine. So you talked about big data, you talk about increasing data resistance, polypharmacy in the elderly, navigating the healthcare system. I think that a lot of you who have had a relative in the hospital will find that without your medical knowledge, it would have been exponentially more difficult. So opportunities. Well, it's the exact same slide, because a lot of the challenges in medicine are just problems waiting to be solved. So let's talk about emerging trends and technologies, and this is where we're going to spend the bulk of our lecture. So if there's anything that you're interested about or wanting to learn more about, just let me know. Okay. So a lot of emerging trends, these are ones just off the top of my head. Who here has heard of 3D printing? Is anyone unfamiliar with the concept? So basically, yeah, you input your computerized model. Say you wanted to model anything from an art piece to your face on chocolate to brand new tissue. You input that into a computerized model, input your source material, whether it's chocolate or living cells, and then print out your end model. And where that's becoming more interesting, we'll see shortly with some examples. Big data. So for those of you who don't know, the amount of data we're generating and the metadata around it. So the data of, for example, how many people are connected in this room right now? How many people are surfing Facebook while we're connected right now? How many people are on Twitter? How many people are not connected right now? And then what are your browsing habits? All right, so one thing you guys will learn about technology is as much of a help it is, it's also a hindrance. And for anyone who's ever had to use an EMR or Alberta Netcare, the Netcare portal, you probably cursed it, but you've also probably been incredibly grateful for it. So big data, the amount of data we're generating about everything we do, from how we feel, how we act, how we interact, is generating lots of useful but also useless information. And our challenge, much like sifting through DNA, is to figure out which is useful information and has an impact on our health, and which of that needs to be discarded, and how to manage that. Someone talked about personalized medicine, and this is a concept that comes from the NIH down south, and it's a 4P concept, so it's personalized, preventative, participatory, and predictive medicine. And so that's more of a concept rather than a technology, but it focuses on the need to do better with more technologies. So rather than saying, you know, your patient X coming into my office, you know, you're presenting with hypertension, here's generic drug X. Knowing your family history, knowing that your ethnicity, knowing your personal risk factors, here's a better drug for you with a better side effect and protective profile. So I want to spend some time now talking about a few key concepts. So we mentioned antibiotic resistance earlier, and I just want to read this quote to you put out by the WHO. And that quote is, antibiotic resistance is happening right now in every region of the planet and has the potential to affect anyone, anywhere, at any time. And that's true whether you're talking about us here in the first world in Canada or a remote, deserted village in India. Bacteria have more resistance than ever before. Has anyone here heard about super gonorrhea? No one's willing to admit it. So that's a huge problem in the UK right now. That they're kind of at their antibiotic resistance limit with how they can treat syphilis, which is almost terrifying, which is incredibly terrifying, because over here you just have to give some Pen-G and you know, your syphilis has been cleared. Some of the data suggests that 50% of antibiotics is inappropriately prescribed. And you guys will hear this time and time again, but it's one thing to hear it. It's one thing to wrestle with your patients within an office. And it's a third thing to finally just say, what is the risk benefit of realizing I have a waiting room full of patients and trying to keep my clinic on time versus trying to stick to the guidelines and not giving antibiotics inappropriately. But I digress. It's kind of interesting that some of the antibiotics that I taught were big gun antibiotics in med school when I was sitting right where you guys are right now are not so big gun anymore. And that's really scary. So Pip-Taz was our big gun machine gun drug of choice when I was in second year. And I finished med school here in 2012. And all of a sudden, Pip-Taz is good enough drug, but there's bigger gun antibiotics because a lot of bugs are becoming resistant to Pip-Taz and needing things like meropenem, which are further line and a lot more expensive. So here's where the opportunity part of the challenge comes in. So in 2015, we had our first breakthrough in antibiotics since the 50s, essentially, with teixobactin. And how that was developed was not discovering a necessarily new organism, but finally having the technology to properly culture this soil species and finally extract the active component of teixobactin. So moving on from antibiotic resistance, does anyone have any ideas of other technologies that you guys are probably using right now? Does anyone here have a smartphone? So like 5 of you have smartphones. Okay, who here does not use a medical app? So you're fairly new in your medical careers, but the more you get out on the wards, you'll realize the incredible innate value of smartphone apps from UpToDate, Medscape, LexiComp. It saves you a wealth of time. It's real-time learning, real-time feedback, and real-time reinforcement of what you're trying to look up rather than having to save it for later or run to the nearest computer or go to the library. So apps are incredibly useful for keeping up with the biggest challenge as a medical student, which I would say right now is keeping abreast of the vast amount of new information that's coming out towards you, and then trying to parse through what's new and what should be accepted, and also knowing where to find the correct sources. The other side of apps is apps for patients. Has anyone here ever seen or heard of an app being prescribed to a patient? So I do it not infrequently. So I often recommend MyFitnessPal app to patients who are trying to stay healthy, track their exercise, track their calories. And I've seen patients and their families who've lost 40 pounds on this. I prescribe pedometers to my patients. And it's not that it's for everyone. It's working, again, with a personalized component. It's realizing what's going to work for your patient. Am I going to give it to my 80-year-old patient who lives in a home and doesn't even know what a computer is? No. Am I going to give it to my 25-year-old patient with a high BMI who has a phone? Probably. Is anyone here interested in neurology, neurosurge? Some people are. So this is a really cool field of study. It's just emerging right now, but it's called BCIs, brain-computer interfaces. And what's really exciting about this is by wiring robotic arms to your sensory and motor cortexes, researchers are giving people who were previously quadriplegic, paraplegic, and insensate the ability to regain these sensations again. And that is powerful and life-changing. It's still in the research phase, but just this week they were able to train monkeys to use wireless signals to move a robotic limb. So having a debilitating stroke, having a trauma isn't the end of the road anymore. And part of this comes from research. I know some of you may want to become clinician researchers down the road. Some of you may hate research and never want to think about it again. That's fine. And And this is where the origins of that came from. So this is an experiment from University of Washington where they had two researchers sit across campus, and one would think of the action he wanted his partner across the campus to undertake. And then the electrodes on the cap he was wearing, this is done by transcranial magnetic stimulation, would read what his intentions were. And then the opposing partner had a cap wired or sensing over his motor cortex, and by reading the signal, he would be forced to move his finger. So this is very interesting, but it's also important to take this in the context of ethics, because now you're talking about the more nefarious side, a little bit outside of medicine, but mind control. But it's being done today. So, sorry, I should have warned you this is going to be graphic. This is another form of innovation. This isn't necessarily a technological advance, but it's just a new way of thinking. It's reframing. We'll talk a little bit more about that if there's time. But this was, for those of you who are interested in plastics and reconstructive surgery, this was a Chinese factory worker who lost his hand in an industry accident. They managed to preserve the hand, but there was too much damage to the stump, and so they had to let that heal up. So to keep the blood supply up to his leg, or to his hand, they actually just grafted it to the leg while the hand convalesced. All right, anyone here familiar with drones, flown a drone, heard of drones? A few of you, yeah. So drones are everywhere now. They're being used for delivering food, for fun, for photography, but now they're being brought into the commercial sphere. And where that becomes important and exciting is there are companies like Zipline who are experimenting with using drones to bring delivery of medical supplies to villages and remote areas in need. And this was first debuted in Rwanda, where the infrastructure and the lack of roads and the lack of power lines doesn't really allow for easy transport, but now it's being debuted in the US. So I talked a little bit about 3D printing before, and I want to spend some time talking about 3D printing in the context of medicine, because some of it is early stage, some of it is research, but some of it is being done in practice today. So in the bottom here, you see, in the bottom left, or your bottom right, I guess, you see a 3D implant of a young lady who sustained a skull trauma, and they needed a bone flap for her. So what they did was they scanned and modeled the defect and then used a 3D printed customized mold to replace the defect. So suddenly she had a skull again rather than a rigid implant that you would typically use to cover the defect. And you're seeing this with prosthetics. You can see that with the boy up there in the corner. They're doing that with heart valves. That's what that little pink thing is. And they're even doing that with burn patients and 3D printing skin right onto burn patients' bodies. Okay, so I want to switch tracks now and talk a little bit about drug repositioning. Did anyone here ever play with a sock puppet when they were a kid? I know that's a really weird question. I'm going somewhere with this, I promise. So my point with talking about sock puppeting and drug repositioning is you have a sock, and once it's outlived its usefulness as a sock, you can reposition it, use it as something else, and use it as a tool for entertainment. And that's what various institutions now are doing with drugs and drug repositioning. So the Comp Sci and Bioinformatics division at Stanford has dedicated a lot of resources to this. And what they're doing is looking at the three-dimensional shape of a drug and then saying, what receptor does it fit that we haven't even thought of before? So they're finding novel uses for antihypertensives and in treating non-small cell lung cancer, for example, or the use of Topamax in ulcerative colitis. Not intuitive, not first line, not something we've done, but a whole new area of research that could become legit within your careers, and that's pretty exciting. And while we're talking about 3D printing and personalizations, has anyone here ever had to wear a cast? Super comfortable, right? So when you hit the wards, they make you do casting workshops. You do it on yourself, and after about 20 minutes, you want to kind of break your wrist or break the cast on a desk because it's so itchy, it's so hot, and it's so uncomfortable. So what a couple of companies are doing now is tracing and scanning the mold or the 3D configuration of the fractured bone and the soft tissue around it, and then making customized moldable casts that will avoid pressure points, and that can be taken off at night and be simply washed in the dishwasher and swapped out with another one. And so you avoid the risk of pressure points, you avoid the smell, you avoid the discomfort, the itchiness, and you can even go swimming or scuba diving or whatever it is you want to do with them. They can be made wet. And then one company went even a step further and said, well, what if we could use the lattice-like structure of this and pair it with ultrasound to speed up bone healing? And while it's still in an early research phase, they found by applying ultrasound at high frequency, they were able to speed up bone healing by 38%. So on the topic of personalization, I want to talk about genomics now. Anyone here ever heard of 23andMe or ever done 23andMe? So that's a company where you'll just swab the inside of your cheek and send off a saliva sample, and they'll read your genome and provide interesting tidbits like this is where you likely originated. This is how sensitive you are to caffeine. This is how likely you are to sustain a venous thrombus embolism compared to the rest of the population. And that's all well and good, but it's not clinical and it's not medical. It's not useful yet. But there is a P2P initiative at Harvard Medical School, and what they've done is they've sifted through the amounts of data, and we talked about this earlier with the amount of metadata that we generate, especially when it comes to genomics. And what they've done is they've taken data and they've made it useful. And so this initiative it's a small trial. They're centering on 100 clinicians and their patients. And they're looking at personal genomic factors and creating a one-page summary for the family physician to use in their office. And it has really useful and applicable tidbits like this is how much more sensitive your patient is to warfarin based on their genomics. And this is how you would dose it differently. And that's pretty neat. So that's early clinical phase, but that potentially has a lot of repercussions. So I included this because I know we spend a lot of time talking about technology and innovation and high tech and research, but the other important thing to remember about this, and for anyone who's ever sat through PCC and patient-centered care, you know that we try to emphasize the lifestyle and the socioeconomic and the hard-to-gauge non-hard science aspect of medicine. And so this is a story out of Duke University, I think. And they looked at the association between stress, specifically divorce, and risks for acute MI, so myocardial infarct. And what they found is if you're a woman, the news isn't good. So if you have a divorce, you're much more susceptible to have an MI. And if you have more than one divorce, you're that much more susceptible to an MI, which the effect wasn't seen as much in men. And so while we're thinking really outside the box, I know there was some talk at the last session that medicine might not be human-driven anymore, and there was talk of AI and robots. What about animals? So we have seizure-sniffing dogs. So this was a really interesting article. I think it was Nature. I would have to double-check. But basically, they said, who is more accurate at diagnosing breast cancer as a pathology? Is it pigeons or is it pathologists? No offense to Kim. But what they found was a single pigeon was 85% accurate, at least as good as a pathologist in diagnosing breast cancer pathology. And then when they flock sourced it to a flock of pigeons, that accuracy became 99%. So again, not necessarily clinical yet, but interesting to think about. Also makes you wonder what your pets can do. Okay, so anyone here a Jeopardy fan, Alex Trebek fan? Maybe here, yes, I see a solid thumbs up in the back. Everyone here heard of Watson? Yeah, so you might have even gone over it at your last lecture. So Watson is an example of a high-level artificial intelligence that actually went ahead and won Jeopardy. And the data set that they plugged into Watson was Wikipedia, all of Entertainment Weekly, and the Bible. And they saw through Watson's immense learning capacity and also ability to contextualize that Watson beat even the best of humans at Jeopardy. And I think if you had that kind of computing power, reasoning power, and brain power in medicine to aid you with diagnostics. We don't have that level of finesse yet, which is why we still have jobs. But in the future, having this type of AI that would help us in our diagnostics and possibly even therapeutics interventions would be really, really useful. Because what you'll learn as you go on in your careers, things that you're taught in med school and out of textbooks are very, very cut and dry, and humans are not that cut and dry. And that's where the importance of a differential diagnosis comes in, and that's where AI still has to catch up. But to have a computing power that has the ability to create differential diagnoses and help us in our clinical acumen would be really, really useful. So I'm going to switch tracks now and talk a little bit about extreme environment medicine. And the reason I'm doing that and where this ties in is, well, actually, I'll kind of paint a picture for you. So I'll turn the question back to you. What do the International Space Station, a remote village in Uganda, the remote Arctic, and an underwater research lab have in common? Yeah. Yes, perfect. Limited resources. So these are all examples of extreme environments in that they are remote, resource limited, and difficult to access. At the same time, we might argue that these are breeding grounds for innovation. And this is where sometimes a lot of technology is bred and born. And to give you some examples, so you heard earlier that some of my background is in the space sector and the technology sector, and I've spent some time researching space spin-offs that have benefited Earth, and also sometimes spin-ins in terms of medical applications that have benefited space. And so to give you some examples, there have been water filtration systems that have been developed for the ISS, the International Space Station, that have been used to provide water filtration to remote villages in Africa. The middle panel up there is an example of a handheld ultrasound, which was initially developed for use on the ISS to scan for both research and for clinical abilities. But it's also been used up in our rural northern communities to help assess pregnant women. Space blankets, I mean, that's pretty obvious. Portable refrigerators that are electricity free, that are run by solar cells, have been used to keep vaccines cold in disaster situations. Portable satellite communications, chemicals that keep fruit and vegetable good for longer throughout the transport chain. These are all examples of spin-offs and spin-ins. And so the point here, and where this ties into technology and fringe medicine, is that it's kind of the mindset behind it. So how do we get and how do we develop these opportunities? And the point is that sometimes constraints are really good drivers for innovation. So I'll go back a couple slides because I don't want to spend too much time on it. It's not the focus of our talk, but for those of you who are interested or might have an interest in extreme environment medicine, you can always check out the fellowship of the Academy of Wilderness Medicine. That's something I'm completing right now, a master's in space studies at the International Space University. If you're interested in the military side, the only way to get an aerospace medicine fellowship in Canada is through the military. And if you're interested, again, in the military, the Special Ops Medicine Association, they really specialize in battlefield, pre-hospital care. So it's really interesting. So those of you who might be interested in emergency medicine might be interested in that. All right. So we've talked about medicine here and now. I want to talk a little bit about out there, what's coming in the future. Because right now, medicine is very much focused on pathology. Where, as primary care physicians, so general practitioners and pediatricians, might focus a little bit more on prevention, but we don't necessarily talk about performance, about augmentation, unless we're maybe talking about sports, but even there we're talking about, that's kind of the realm of sports psychology. So question for anyone here, if you had the ability to have a photographic memory, would you choose that option? Just raise your hand, yes or no. Okay, what if it was the night before your finals and you hadn't studied? Would you choose that option? Okay, so this is I'll get to that in a sec. But I actually want to take you through a scenario here. So I want you to imagine that it's 2024, years down the future. You're a 10-year-old kid named Joel or Billy or whatever kids are named in 2024. And you have the day off from school, and you decide to go and play some video games before breakfast. So you slip on your virtual reality helmet, and you shoot some bad guys. And it's like Space Invaders, but the graphics and the resolution's really, really vivid. And then you finish your video game. Except what's turned out that's happened is in slipping on your AR helmet, your virtual reality helmet, is you've actually been delivering targeted therapy to someone with a known tumor. So this is really fringe and out there medicine, but my point in giving you examples like this is to spark your imaginations for those of you who might want to be on the forefront of medicine and wonder what else is out there that's still left to be discovered, and what technologies might help you in doing that. Okay, so we were talking about photographic memories. So it's being done today. So this is a study from the New England Journal of Medicine. I believe, no, it's not of the University of Toronto, it's somewhere else, but what they found was by performing deep brain stimulation in the entorhinal cortex of patients that they were able to mimic and improve visuospatial memory. So that's actually a thing. Whether is it ethical, does the risk-benefit ratio favor the benefits? Will it be commonplace? Probably not today in 2016. Will that be the case in 2075? Especially once, maybe by then we'll have cured chronic disease, infection, cancer, AIDS, diabetes, and medicine will have to find a new focus. And maybe that will be human augmentation performance. For those of you who are interested in this kind of stuff, DARPA, the American Defense Advanced Research Project Agency, their whole mission is to think of crazy stuff. So in one presentation I saw by them, they were focusing on mechanical respirocytes. So what if you were to inject mechanical respirocytes, mechanical blood cells essentially, and be able to breathe underwater for hours instead of minutes? What if you could slip on augmented reality glasses and suddenly have instant information, or even use that with radiography and have your eyes be their own X-rays or MRI or ultrasound? Anyone here a Star Trek fan? A few of you. The tricorder, there's currently races and prizes on today to develop them, and there's one Canadian company still left in the X Prize competition to develop the world's first tricorder. That is a handheld, non-invasive diagnostic device that can diagnose fever, infection, and they have like an entire 10-bullet list of most common infections or pathologies that need to be diagnosed with a non-invasive device. And that's pretty cool. So in the time that's remaining to us, I want to talk about the mindset behind this. So this is a little bit less hard textbook medicine and a little bit more on the psychology side of it. Still evidence-based, but maybe a little bit less what you're used to. So what drives innovation? What drives new breakthroughs? According to research, stealing this slightly from Harvard Business Review, comes down to 4 factors: mindset, people, environment, experience. Okay. So by mindset, and I think you've touched on this in your last lecture, I want to talk about exponential thinking. Okay. Before I do, I want to get you thinking about how you think. So what are jobs that existed 10 years ago that don't exist today? Anyone? Travel agent. Yeah, Expedia, Travelocity, that's what I use. Anyone else? Blockbuster store manager. Yes. One more.
Cashier at McDonald's.
Cashier at McDonald's, or even cashier at Walmart. Those things are automated now. Okay, next question is jobs that exist today that didn't exist 10 years ago. Yeah. Uber drivers. Yeah. That's a good one. Yeah.
Social media expert.
Social media expert. There's still some debate as to whether that's real. But I will accept it. Yeah. What else? Okay. So, yeah, go ahead. App developers, yeah. So it's number one on my list. Data miners. This one I really don't believe is a thing, but millennial generational expert. My personal favorite, Zumba instructor. The 400-fold growth in the past 5 years. Sustainability experts, user interface and design experts. The world is changing very, very rapidly now at an exponential pace. And in fact, jobs that exist today aren't going to exist in 10 years. So before I get to my next slide, what are jobs that exist today that aren't going to be around in 2026?
Taxi driver.
Taxi driver, yeah. Jobs that exist today. Anyone? Yeah.
Taxi drivers?
Taxi drivers. So taxi drivers really won't be around. Sorry, he just said it. Won't be around in 2026. A lot of jobs are going to be lost to automation. We see that already. So retail checkout, if you've been to a Walmart or a Target recently, those are automated. They're kind of split right now. They're not fully automated, but they could very well be in 10 years' time. Telemarketers, still just as annoying with automated robots, but they'll be turned into automated systems. Same thing with anything delivery related. There'll be drones, automated driving cars, travel agent we heard about. Postal workers are slowly, even today, are being drone deliveries being experimented with. Word processors and typists. Now we have voice recognition. And who knows what's going to happen to the millennial generational experts and social media managers of today. Okay, so we've talked about things that don't exist anymore. What about jobs that are likely going to exist in 10 years' time? Let's start thinking about the horizon in the future. Anyone?
Robot liaison.
Robot liaison. Yeah, you're a robot human relationship counselor. Anyone else? All right, well, I have a list. Someone say something? Okay, so waste data managers. We talked at the beginning of this lecture about the sheer amount of data that we're producing as a human race every single day and the need to be able to sift through that information. To give you an example, the Large Hadron Collider generates yottabytes of data. The LHC alone generates more data than all of human history has ever generated. And they only use, I think it's 10 to the minus 6% of that data. So what do you do and how do you sift through all that data? How do you apply that to medicine? Second on that list is healthcare navigator. So as medicine becomes increasingly specialized, especially if you go into a specialty, get your fellowship, subspecialize, is going to require a lot of outside help to navigate. And to give you an example, a couple of years ago when I was fresh into residency, my uncle, he had Parkinson's. He didn't speak any English. He was nearly mute because of his Parkinsonism. He fell and he broke his hip. And then he went to the hospital, and then he developed urosepsis. And it generally was a pretty grim picture. And every day that I went to see him, I kind of had to act as a translator between my family and the nurses and the physicians. So I had to ask, what is his white count today? What is the step-down plan for his antibiotics? What is his mobility? What is his rehab plan? Is he on a dysphagia soft diet? And if I hadn't been through ridiculous amounts of post-secondary training, I wouldn't have been able to provide that translation. And so I think that's a really important area to focus on. We talked a little bit about augmented reality as an emerging technology. And in fact, the world's first augmented reality amusement park opened earlier this year down in Utah, of all places. So it can just be like that guy out of the Matrix. Like, that would be your job, to build virtual reality simulations. And taking that back to medicine, how can you use virtual reality simulations to train the next set of physicians? That would be tremendously useful in surgical specialties and hands-on specialties. 3D printing engineers, we talked a little bit about that earlier. Privacy managers. I mean, privacy today with social media is not what it was in the past. Extinction revivalists. So anyone who's seen Jurassic Park is not outside the realm of possibility. All right, so I won't spend too much more time on that. I want to shift more now to exponential thinking. So I need 2 volunteers. I'm going to just randomly pick up people. Back there. All right. Anyone else? Second volunteer. Yes, right there. Looks so thrilled to come up. All right. So what's your name?
Monty.
Monty, nice to meet you.
Nice to meet you.
And what's your name?
Glenn.
Glenn. All right. So I'm going to get you guys to stand right by that desk over there. Okay. So, yeah, and stand side by side. Okay. Facing me. Okay. You guys are in a race. So does anyone remember geometric and arithmetic sequences from school? Good, because we're about to revisit that. Okay, so we're going to go in a 5-step progression, but Monty's going to move in an arithmetic fashion. Glenn is going to move in an exponential fashion. So for every time I say step 1, you're going to take 1 step. For every time I say step 1 or step 2, you're going to double your previous steps, okay? So step 1. 1 step, okay? Step 2. 2 steps. Step 3. How far will we make Glenn go? Okay. Step 4. We're actually just going to send Glenn home early. All right, so you get the point. But even 4 steps down, we're already at a significant gap. And this is what exponential thinking is, realizing that things are no longer progressing linearly, but doubling at a very rapid rate. Thank you very much. You guys can sit down. Okay. That was Oscar worthy, you guys. Thank you. Okay. So where that comes into application is thinking of that in terms of technology. So let's look at communications as an example. Back when radio came out, it took the radio 38 years to reach 50 million people. Okay. Facebook came out in 2006. It took Facebook 2 years to do the same. The last Taylor Swift video took 12 days to reach 50 million people. So that is what I'm talking about when I'm talking about the rate of exponential change. So how does that apply to you? I was sitting where you guys are sitting not too long ago. I started med school in 2007. And things that I've learned already have become obsolete. Antibiotics that I thought were taught were big gun antibiotics, things that I was taught were the gold standard, have changed. And now the rate of research that's being generated on a daily basis is changing so much that sometimes I say, because I'm a sarcastic person, if you don't like the research, just wait 5 years, it's going to swing back the other way. So for example, or sometimes the research won't be even that, will be equivocal. And you'll have to make that distinction as physicians. Okay. So bringing this back to technology and tech development, learning to think exponentially and learning to project and learning to think what is this emerging technology and how it might be useful is going to take you a long way, whether you're talking about virtual reality, 3D printing, big data, personalization, antibiotic resistance. Okay? So here's another example when we're talking about disruptive thinking. We're shifting away from exponential thinking now. So bookstores used to be the only place you could get books. Then along came big box bookstores like Barnes & Noble and Chapters. And then someone said, well, what's the next step from that? And that's where Amazon came in. They said, how do we disrupt the bookstore business? And they did that by creating warehouses. And they weren't thinking necessarily, or they were realizing that they needed to be the disruptive force if they were to stay ahead of their own game and not go out of business. And they disrupted themselves by creating the ebook reader. Same thing with Blockbuster and Netflix. They were thinking Netflix managed to disrupt, or Blockbuster is no longer around because they weren't thinking ahead. They didn't see that they would be disrupted by the digital industry. Netflix started as a mail-in DVD service. It's now strictly online. Okay. So in the few minutes here that remain to us, while we're talking about mindsets of disruption and innovation, I want to talk to you about the importance of questioning everything. As a physician, this is incredibly important. On a less technological side, it's just important to be a good physician. It's important to develop your spidey sense. And you'll see this the second you get out in the clinical area, on clerkship, on the wards, that you will always have to find your own story. No matter how many people have asked it from a patient before, no matter what someone else is thinking is going on, you have to learn to question everything. And that questioning can sometimes lead to discoveries. That's how penicillin came about. That's how x-rays were discovered. How can things be better? And how can you make them better? So just in case you were feeling like you haven't done enough with your life, here's an 18-year-old who spent her summer vacation creating a portable, suitcase-based dialysis machine, because she thought, well, having a dialysis machine the size of a refrigerator that's $50,000 isn't practical, affordable, or accessible to people who might not be in big centers. And so that's what she did. Okay? You also have to ask what if sometimes. Okay? Do you guys still have triple eye block? No? Do you guys still learn about infections, hopefully? Okay, good. Awesome. Does anyone who know who this guy is then? Semmelweis. Awesome. Do you know what he did? Follow-up question. Yes. Okay. Well, you retained it. That's awesome. So this is Semmelweis, and he had this crazy idea in Austria in the 1800s saying, hey, what if mothers are dying of puerperal fever post-delivery because physicians are the source of germs? And it was a crazy idea at the time, but he ran this study. It was actually a randomized, or a controlled study, because he had two clinics, one where he made the physicians wash their hands, and then the other one where it was either the midwives or people weren't washing their hands. And he found that by introducing hand washing, he was able to reduce mortality to about 2.8%. And it's this really inspiring quote that he came back. He said, when I look back upon the past, I can only dispel the sadness which falls upon me by gazing into that happy future when the infection will be banished. Conviction that such a time must inevitably sooner or later arrive will cheer my dying hour. So it doesn't have to be a high-tech innovation. It just has to take thinking differently. So maybe next time you're out on the wards or Gilbert Scholars, do you guys still do that? Kind of. Does anyone teach you anything? Good question. Yeah, so next time you're in clinical practice, or even if you're learning a new a concept, question it and ask, what are the repercussions of it? Not only will it help you think more critically, but it could, if innovation is what you want to be a part of your medical career, it'll set you on your way into developing that mindset. Okay. I'm not going to spend too much time on the next few segments because I think they're pretty self-explanatory. You guys still have to do multidisciplinary group teaching. Okay, teams are good. Multidisciplinary interaction is good. Having different viewpoints is good. Having people come at problems from different angles is good, because you have a skill set that someone else doesn't have, and vice versa. That's all I'm going to say about that. All right. So how do you cultivate open questioning environments? Okay. Part of it comes from doing exactly what we were just talking about, asking questions and encouraging others to do the same. And being in spaces that allow for that. So I think this is a pretty good example compared to if you go into any of the older lecture theaters, if they're still around on the other side of campus. You guys are closer together, you're not bound apart, you have your computers, you can communicate with each other. Having a physical workspace in which you can do that too is important. Okay, and then using technology at your fingertips. So 2016 is in fact an amazing time to be alive, because if you want to learn about something, you can do it by reading about it, by practicing it, by simulating it, by learning about it online, by watching a YouTube video. Okay? If you want to design something, or you want to have a platform to publish something, whether it's a blog, whether it's audio, whether it's video, you have that at your disposal. So my point is, the environment right now is ripe for you to learn to embrace technology. Okay, And then experience. Again, I won't spend too much time on it, other than to focus on the 5 factors. This is from a Harvard Business Review study of leaders who were at the top of their game in innovation. So they surveyed the baseline population and CEOs of Fortune 500 companies who are also noted to be the most innovative. And they found that people who associate, draw ties between things, who network, who experiment, who ask questions, and who simply observe were the most innovative. And even if you don't care about innovation, even if you've gone for a bike ride in your mind at this point in the lecture, try to ask yourself how you can incorporate those into your clinical practice. Because sometimes observation is all it takes to realize what a patient is telling you or not telling you. And sometimes associating factors. Sometimes patients will come to your office with a bullet point list of 17 points, and you'll be ready, you'll be at your wit's end, they'll be at your wit's end, and then suddenly you'll have this aha moment and realize they're all connected. Okay? So my bottom line to you is question, observe, and experiment. Okay? So we're at the end of our time here. I hope to let you go a little bit early. Okay? So we talked about 3 things today just to bring it back. We talked about our greatest challenges in medicine. We talked about our greatest opportunities in medicine, which are one and the same. We talked about technologies that aren't, we talked about some technologies that are far off, pie in the sky, that might be decades down the road. But we also talked about a lot of technology that is emerging here and now today, things that you could actually even go home and use today, whether it's an app or a learning tool, okay? So for those of you who might want to take this a step further, who might want to learn to dig a bit deeper or just shift your mindset, I have your totally optional homework, which I know that all of you are going to embrace on this Friday before a long weekend. So I want you to ignore what's on the slide. I want you to take a notepad and a piece of paper and a pen, and just for the next 2-3 days, everywhere you go, just write down your observations and your questions. And firstly ask, how can this be better? And how can I make this better? Okay? And so if you're shadowing this weekend, if you're working in the merge, so much the better. Look out for inefficiencies. Even if you're just spending time at home or if you're using public transit, I promise you, things can always be made better. So that's it. It's 4:29. We are at the end of the lecture. I welcome any questions you have. Other than that, you're free to go. Just kidding, you're not free to go. Sorry.
No, but questions is a very good idea. So are there any questions for Shawna? Yeah.
Okay, sorry, I was wondering if you could maybe talk about why you chose family medicine, because it's obvious that you're a very forward-thinking person, and I'd just like to see, like, or have you maybe talk to us a bit about, like, what led you to choose that specialty, like, with an eye towards the future?
Fun fact, I started out in neurosurgery. So I didn't choose family medicine to start with, but I chose them for similar reasons. Maybe not. So family medicine has been fantastic, particularly the program at this university, in that they really encourage you, if you have outside interests and require maybe a little bit more time away from the program to pursue those. So that's one of the reasons. The other reason is that family medicine is really build your own practice. So I'm on rural right now. The reason I was late is because I just drove up from Edson. And the physician I'm working with right now is fantastic. He does clinic, emerge obstetrics, as well as surgical practice. So you can absolutely build your own practice. There's a lot of work to be done everywhere in medicine. So my mentor in neurosurgery, when I was still gunning for neurosurgery, was Garnet Sutherland down at the U of C, who invented the NeuroArm, which is one of the world's first neurosurgical robots that's MR compatible. At the same time, in family medicine, there's so much in terms of EMRs, keeping on top of your patient screening guidelines, keeping on top of the vast amounts of new information that's coming out. So I don't think it's so much a specialty-specific thing. I think it's a program-specific thing and a university-specific thing. And I think it's also an individual-specific thing.
And a follow-up question to that is, I'd also just like to hear your thoughts on what you see as maybe certain specialties that are better poised to deal with the disruptions in technology that we're going to see, or maybe those that are less well equipped to deal with such disruptions.
So I'll admit that I'm speaking from a biased perspective. So I've spent a lot of time in the surgical sphere and a lot of time in general practice with minimal time in between. So surgery is very forward thinking. So once upon a time, I was a plastic scanner, and there's a lot of innovation there because it's essentially biological alchemy. You're switching around body parts, you're switching around blood vessels, transposing things here and there. So we saw with 3D printing for skin grafts. You see that as well in facial reconstruction. You see that in neurosurgery, 3D printing for skull defects. So surgical specialties, urology with the Da Vinci robots. I think any surgical specialty, I think there's first of all a competitive onus to say, hey, look at us, we have new toys, so we're amongst the best. But also there is definitely, in a lot of cases, a benefit. Family medicine, because there's a lot of room for observation, because the challenge of family medicine is dealing with a large breadth of things and managing that and dealing with complex patients who may or may not even know why they're there. So that's what I can comment on. I can't comment on things like obstetrics or internal medicine or pathology, although Kim, maybe you can.
Well, I think all fields are changing. I mean, that's part of the reason of talking about the future. But like there are new challenges coming. Like right now, my main focus is transplant pathology, but tissue engineering pathology will be 10 times as large. We can only transplant 10% of the people who actually need it, whereas stem cell replacement of organs, in theory, could supply that for everybody. Are all stem cell generated organs normal? No, there are a myriad of different ways in which things can go wrong. So that's just one example of kind of the excitement about not only the general occupations that don't exist, but even the medical occupations. If you look up tissue engineering pathology, you won't find that anywhere. We plan that in 2-3 years that'll be a household word, household phrase. So you can't really find a precedent of just somebody else in a field and plan to have a career exactly like that person. It won't be like that. But the medicine of the future, I think, can be substantially more satisfying than what medicine has been up until now. I think you've made a good career choice. Of course, I'm somewhat biased, but I strongly feel that. And you'll probably remain employed a lot longer than people in other jobs who will be on this permanent, vacation bit way before you will. So other questions? I had a few other, yeah.
With all this talk about getting unemployed by robots and AI and so forth, what kind of vision do you foresee for the future? Like, what is the role that people will have? Like, or is no one going to have a job?
I don't think that's going to happen anytime soon, not in the next couple of decades. What is the role of the physician in the immediate future? Being an information manager, maintaining a top-level view, especially in primary care. So as a primary care physician, you have to know what your patient's cardiologist, endocrinologist, respirologist are all saying, and then interpret that. And then if there's conflicting information, somehow manage that, communicate that back. Hypothetically, if there was a situation, say, by 2025, in which Watson was suddenly able to treat and manage every patient in the world, again, I don't think that's the case. Physicians are a pretty resourceful bunch, and what you'll find is that there's something in medicine for someone that is of interest. So then our shift may go to research, or it might go to human performance and enhancement. Again, I think that's a lot far off, but I don't think I don't think we'll ever, throw in the towel, say, hey, that's it, no more medicine, we're done.
The thing that would change that would be moral failure, right, of physicians as a group. And I don't see that happening. But like human enhancement, if it turns out we're absolutely incapable of making those moral choices that would be a part of that some other category of human being can do that much better, then that would be a problem. So I think you're not just passive victims of the future. You can sort of shape the future. If we're able to help you to kind of envision what that future is going to be, I think that makes it easier for you to shape the future. And you can make sure that physicians continue to have interesting, satisfying lives, like by making them in charge of a lot of new stuff out there that is central to the happiness and well-being of human beings forever. Okay, I'd like to just go over a few other things. So, I've been taking pictures since the age of 12, and that camcorder has been taking pictures the last 5 years. Which one of us do you think's better? So the camcorder is way better. And what's the best picture it ever took in the last 5 years? It's actually this picture here of you guys. So there used to be a picture of Osmer Zayan holding his arms above his head, and we submitted that to all sorts of photo contests and so on. And that used to be the best picture that the camcorder had ever taken, but now it's you guys. So I thought you would find that somewhat meaningful in that it impacts you directly. Now, we plan, if you will allow us, to make rather wide use of this photo, since it is much better than any that I could ever take in my entire extended life. And if any of you who are in this photo strongly object to us making important use of this photo in the future, please let me know. Now, if some of you have been feeling like internal resistance to some of the things we're talking about, kind of a friction inside, that's normal. But it's also a characteristic of some of the high points of your medical school career. When things come up that challenge your existing belief systems, then you tend to learn more in those moments. But what do you do when you're dealing with an area where most people resist? Like the idea that, obese people, it's not a moral failing, that, that they're not all out of shape, they're not all sick, and so on. Most of us, naturally, when we look at somebody who's overweight, we have this cognitive bias that kicks in. And the same thing's true of thinking about the long-range future. You will find that you have a natural resistance to that because it's not relevant to right now. The average human being is like the average politician. They're interested in the next 3 or 4 years until the next major life event, the next election. So what do you do about that? How do you interest people in things they don't want to hear about? Well, as you might feel sitting here, just lecturing to them, even if they're forced to be present, doesn't work very well. So that's the idea behind trying to reach a broader audience by incorporating poetry, music, the sound bites of modern life to kind of broaden the number of people who would be interested in the important questions that have to do with the future. And I'm quite proud that we seem to be succeeding at this. We've done some local events, and we did one at the Vortex Jazz Cafe in London. And so what's happening about that? It has to do also with the students working with me. So they're putting together a book of my poetry and photography. They would like that to use that picture of you guys, and it's all sort of coming together on December the 8th at noon in ECA 2490, when for the first time I'm giving a session in the Arts and Humanities and Health and Medicine speaker series. And there may be a few of you who'd like to come. I hope that there may be a few. I'm not trying to force anybody, but by that time this book will exist, and the picture of you guys will be in it, and there'll be a PDF of it, which I can send you for free, but there will also be physical books there. And you may be interested in kind of this story that we have to tell of why it's important to try to reach people who would never sit still for a lecture on something, and sort of trick them into learning about it through poetry, song, and other means. So I would welcome any of you who do wish to come along for that session. And finally, there will be opportunity for you to give feedback on the 4 hours we have provided to you, and that's very valuable to us. And whatever you feel about it is useful to us, and we welcome that. There are only 2 medical schools in the world that are teaching stuff in this speculative future area, and the name of the other one was actually mentioned by Shawna. At Semmelweis University in Budapest, Hungary, they have a required medical student course called Disruptive Technologies in Medicine. They teach about the technological singularity, machine replacement of human labor, all the stuff you've heard about from us. It's only 1 hour a week, but it runs for a really long time. And so that's it. There's the sessions you've heard here, there are those there, and I think there's no other medical school in the world teaching this at the moment. You have the power to shut it down. If you think these 4 hours are something that should have never happened, in your feedback, you can say that. And also, if you want more of it, you can say that. And if you want to give us some ideas of what you'd like more of, that is also possible. But I consider it a great honor to have had the opportunity to teach you these 4 hours. I hope it expands in the future, but even if this is the last time, I feel that way. So that's it. Thank you very much. If you're in the picture and really upset about our use of the picture, please come see me. Thanks very much. Bye-bye.